So thank you so much, Rachel, and thank you for the invite to this meeting. I'm Anne. I'm an economist at the Health Foundation, specifically within this team called the RAIL Center. So RAIL is an acronym that stands for Research and Economic Analysis for the Long Term. So we were previously sort of the economics team that underwent a bit of a rebrand. And we are essentially focused on doing, long-term projections analysis. So looking at making sure that policy making is not just focused on the short term, that we are looking at the long term as well, but also then making sure that those decisions are then built upon a very good evidence-based underpinning, good long-term analysis as well. So that's essentially what our team's very sort of high level aim is. And today I'm here to talk to you about this work that we did in partnership with the University of Liverpool, where we looked at the current and future patterns of inequalities in diagnosed illness by deprivation. So I will move on to the next. So just to give you a quick bit of background and context, and apologies to anybody who has already attended the hacker presentation, because this will basically be near identical to that. So just to give you a little bit of context, so obviously, a lot of you are aware about the existence of wide health inequalities in England, and we are specifically talking about inequalities by socioeconomic deprivation in this case. Obviously, we know of the existence of inequalities across other characteristics as well. You know about the 8 to 10 year life expectancy gap and the near 2-decade gap in healthy life expectancy. So because this is an area of research that has a lot of work that has gone into it already, what is it that our new research is adding? So a lot of the existing measures of health inequality, so things like healthy life expectancy, for instance, or disability-free life expectancy, are actually measures that use self-reported health. So they're asking people in surveys, how would you rate your health? And you would say very good, good, poor, or something along those lines. And so essentially, a lot of the measures are using self-reported health, which are very valuable. So what we are doing is we are complementing that evidence by looking at inequalities in diagnosed illness, which also allows us to look at things in a lot more granular detail. And I will obviously go into detail about the specific data sets that we use in the coming slides. So that is one, that we are able to look at existing patterns of inequalities in a lot more granular detail. But also, this is one of the first studies actually to project what inequalities in illness are going to look like in the future in England. So we think that that's a really valuable angle to this research. And also, we want to show that, this is not really just a health issue. This is something that has wider economic implications. So a lot of the results that I will be presenting will be focusing on the working age population to sort of show how that potentially could have knock-on effects on, economic inactivity and labor supply, even though we don't measure those outcomes, but just to give you a flavor of, what could be in store. Great. So moving on to the Health in 2040 series. So this is a long-term program of research, like I mentioned, with the University of Liverpool. We had part one called Health in 2040, which I actually presented at Hacker last year, and Anita Charlesworth, our director, presented at one of the keynotes this year as well, where we looked at the overall projections of diagnosed long-term illness in England. And so this is part two, which was published a few months ago this year, where we are doing a deep dive, but broken up by socioeconomic deprivation. And so why is this different? So we have actually been doing projections for a while now, like different iterations of this, and how we think this is a big improvement over previous versions is because of these factors. So one of it is that we have better data. So we are using sort of linked primary care, secondary care, and mortality records. So this is CPRD ORM for primary care. Secondary care obviously is hospital episode statistics, and this has been supplemented with ONS mortality records. And so this gives us a lot of granular detail into people's illness history. So it's a very rich data set. So that is one. And then the University of Liverpool, they have developed this microsimulation model called IMPACTNCD, which has been sort of developed and validated now over a decade. I think it's been used in papers and published and cited and things. So it's a very well established microsimulation model that helps us give a better understanding of the relationship between long-term illness, aging, and multimorbidity. And what the model also does is, and I'll go into a little bit more very high level detail about the model, but what it does also is that it incorporates, rather than just drawing straight lines through patterns of illness, what it does is the starting point is actually trends and risk factors. So it takes things like, alcohol, smoking, BMI, diet, and then take using the epidemiological evidence that we have about the causal relationships between different risk factors and illness, then uses that to then project illness forward. So that's what it does. And also in terms of how we measure multimorbidity as well. So, a lot of people use numbers of conditions. And so what we did is we thought maybe we need something that reflects healthcare demand a little bit more, because obviously numbers of conditions, if you just say more than 2 conditions, that really has very different implications based on what the 2 conditions are, right? So we wanted some way of standardizing that information. And we came across this score developed by researchers at the University of Cambridge called the Cambridge Multimorbidity Score. And I'll again go into a little bit more detail about what that entails in the coming slides. So at a high level, this is essentially what we think is giving this research, is really strengthening the research in terms of the results that it's producing. Right, so moving on to methodology then. So like I mentioned, one of the key things that we use is something called the Cambridge Multimorbidity Score to measure multimorbidity. And so this is an aggregate score that assigns a weight to 20 common sort of high cost, high prevalence conditions based on their impact on 3 things. So their impact on primary care appointments, emergency admissions, and their risk of mortality. So based on these 3 things, you have a combined sort of a single score for each of these 20 conditions. And then so for instance, if you had a patient with multiple conditions, you would be able to just add up the scores for the different conditions that they have, which then gives you an aggregate multimorbidity score. And this allows you to then compare across time or compare across different population subgroups. Specifically in this research, we are looking at something called major illness rather than looking at any non-zero CMS. And so this is a threshold of 1.5. And so basically, if anybody has a score greater than 1.5, we define them to have major illness. And so based on the table that you can see on the right-hand side, that is the 20 conditions in descending order of weights, you can see that unless if you had dementia or cancer, you would only reach that threshold of major illness if you had multiple conditions. But in the case of dementia or cancer, those conditions by themselves will put you over that threshold based on the weight that we have, the threshold that we have chosen. So yeah, so that's basically the 20 conditions that they have, and together they account for around 2/3 of the burden of illness in England. Right, and then moving on to the model as well. So, like I mentioned, the microsimulation model is called IMPACTNCD. It's open source, and what it is doing is basically it is combining individual level data on demographics and survey data on risk factors coming from the Health Survey for England, and then using, like I mentioned, epidemiological evidence on the causal relationships between risk factors and long-term illness to then project illness. So if you look at the diagram, it's giving you a very quick, like a picture of how those different things feed into each other. So for instance, if we start with the demographic characteristics, so things like somebody's deprivation, age, ethnicity, region, so the wider environment, we know that that then influences the likelihood of having a risk factor. So the behavioral risk factors are things like, diet, alcohol, smoking, and then the biological ones are things like cholesterol, systolic blood pressure, BMI. We then know that based on the different risk factors that you have, that then influences the likelihood of developing different diseases. So that influences incidence of specific conditions, but then it also influences mortality of having an illness. And then we model for remission as well. There are some of our conditions, you can recover from them. And then, so incidence, so all of these things together, they then influence prevalence. So the share of the population having the illness at any given point in time. And then you can then use that for to then aggregate it up to show sort of multimorbidity trends. So yeah, so that's the model at a high level. So now if we move on to some key findings. So what is happening in terms of now? What do we see for diagnosed health inequality? So this chart is showing you the share of people with major illness, the metric that I mentioned earlier, broken up by age, a 10-year age group, and by decile of deprivation. And what you can quickly see is that that socioeconomic gradient that we are quite familiar with when we look at health inequalities metrics is coming through very clearly here as well, that there is always much more, the prevalence of major illness is much greater if an area is more deprived. And in the 20 to 29 age group, even though overall prevalence of major illness is very low, as you would expect, there is still some level of inequality within those very low levels of major illness. And then it is just constantly growing throughout working age. So the red versus the gray is just to highlight working age versus older ages. And until you reach the 80 plus age category, where actually it looks like there is a bit of a leveling, but that is actually because people with the poorest health in the most deprived areas have already died by the time they get to that age group. And so there is not so much of a difference between people then who then survive to that age among the most and the least deprived areas. So that's essentially why you see that leveling in the 80 plus age group. But also, yeah, when you look at the working age, if you just focus on the working age, for instance, you have 15% of people, and by working age, we mean 20 to 69 years. So that's what we've used to sort of define working age throughout the report. 15% of people aged 20 to 69 have major illness in the most deprived decile, which is more than double the rate that you see in the least deprived decile, which is 6%. And so again, like I mentioned, because we are looking at health records, this allows us to dig into some of the conditions that are contributing to the inequalities in diagnosed illness. And so, like I said, the Cambridge Multimorbidity Score is made up of 20, but when we checked, actually only a group of 7 are contributing to pretty much all of the inequalities that we observe in diagnosed illness. And so these group of 7 conditions are chronic pain, anxiety and depression, type 2 diabetes, COPD, and then you have some cardiovascular conditions like coronary heart disease, stroke, and heart failure. And again, this chart is showing you the age standardized prevalence of these 7 conditions for the population age 20 plus, broken up by deprivation again. And again, you can see that socioeconomic gradient coming through very clearly in this chart as well. COPD, for instance, has the highest relative inequality. So if you take the ratio of the most to the least deprived prevalence, so that's 4 times people, the prevalence of COPD in the most deprived areas is 4 times that in the least deprived areas. And then, so what we can also do is, so what we did is we constructed an alternate measure of life expectancy or healthy life expectancy using our metric of major illness. So again, like we said, healthy life expectancy is using a self-reported health measure. So we wanted to see, okay, what does this look like if we used a diagnosed illness measure? And so we are basically defining the state of good health as being free of major illness, right? So over here, this is showing you the total length of the bar is basically life expectancy. That is split up into the expected number of years that you would spend without major illness, and then number of years you would spend with major illness. And this is just for women. And so you can see that there is a 10-year gap in the major illness-free life expectancy, so to speak, which is the red bit, between women living in the most and least deprived deciles. And it's actually quite similar for men as well. It is a 10-ish year gap for men as well. And so again, what comes through quite clearly, we already know that people in the most deprived areas, they die much earlier. Their life expectancy is lower. But then you can also see that out of the shortened life that they have, they are still spending more time with major illness. Right. So that's sort of setting the scene for what is happening now. What do we project into the future? So if current trends in risk factors were to continue as is, this 10-year gap that you see across the most and the least deprived areas, that is going to stay the same. So health inequalities are not really going to go anywhere. They will quite stubbornly persist if things were to continue as is. And so what this is showing is, again, we are trying to see what this means for the numbers of people. So till now, I was showing you things that are sort of like shares and life expectancy, whereas this doesn't really give you a sense of what does this mean for healthcare demand? And for that, we need to know, what does this mean in terms of numbers of people, right? So what this is showing you is the change in the number of people between 2019 and 2040, and that is broken up into people with and without major illness by decile of deprivation. And so what we project is that between 2019 and 2040, the number of working age people, and this is just 20 to 69 years, the number of working age people with major illness will increase from 3 million to 3.7 million. So that's a 700,000 increase. But what we see is that increase is not going to be evenly distributed. 80% of that increase will be in the more deprived half of the country, so deciles 1 to 5. And that's what that is what that curly braces is trying to show, is how that growth in working age ill health is quite unevenly distributed. And then again, just to look at the conditions, what is the picture for specific conditions when we look at inequalities. And so this is showing you the change in the age standardized prevalence between 2019 and 2040. And what we see is actually it's a different picture for different conditions. And we're just focusing on the 7 that I already spoke about. And so if we start from the right side of the chart, that is showing you a positive picture. So that's showing you a picture of sort of public health success. That's showing you a picture of narrowing inequality. That is sort of what we want to see. And so you can see things like CHD and stroke sort of falling across the board, but falling more in the most deprived areas. And we know that a lot of this can be attributed to successes in smoking, reducing the prevalence of smoking, and also things like the use of statins as well. And for instance, if we looked at smoking, people in the most deprived areas are more exposed to smoking. So a policy that targeted something like smoking you would imagine would have a bigger impact on those areas. And so that's exactly what we see here, is a bigger reduction in things like CHD and stroke in the most deprived areas. But on the left-hand side, we are seeing the exact opposite, right? That is the direction that we don't want to go in, is for type 2 diabetes. We are seeing an overall increase in prevalence between 2019 and 2040, but the increase being greater in the most deprived areas. And this is largely attributable to obesity. And so we know that obesity is a risk factor for diabetes. And we actually project that obesity is going to slightly increase overall in England up on to 2040. And so because, again, people in the more deprived areas are more exposed to obesity, there is a greater increase in obesity-related diseases like type 2 diabetes in the area. And chronic pain as well. I think people were quite interested in HACA, and there were some questions. So in the case of chronic pain, actually, technically that is a narrowing of inequality, but again, in the sort of wrong direction. Like, that's not what we want, because there is an increase in the prevalence in the less deprived areas. And so if you then compared the most and the least deprived areas, we would define that as a narrowing of inequality. And that is because chronic pain is actually not causally linked to any of the risk factors that we have. So that is being determined by a combination of population aging and its link with other conditions. So within the model, it's not just that conditions are linked to risk factors, but conditions are also linked to other conditions. And so with chronic pain, because it is quite linked to a lot of the other conditions that we model, that's essentially, and the fact that the less deprived areas are having greater population aging, that's sort of why we are seeing the pattern for chronic pain. So it is a narrowing of inequality, but again, not what we want to see, because it's increasing prevalence in the less deprived areas. And then finally, again, what does this mean for the numbers of people? So out of those 7 conditions, again, we have 3 that are the most prevalent across the most and the least deprived areas, and in 2019 and 2040. But what you see here is that actually, even though these three conditions are projected to be the most prevalent in the most and the least deprived areas, that growth is actually much greater in the most deprived areas. So yes, this again has obviously huge resource implications and healthcare setting implications as well. So yeah, so those are the results of the research. What do we, what does this all mean? So I think the key thing is just to say that it is slightly a bleak message. Wide health inequalities, I mean, sadly, they are not going anywhere. They will persist, and with implications for health and the wider economy. So we saw that obviously major illness, the onset of major illness is quite early in the most deprived areas, and this has huge implications for individuals and their loved ones. But also, if you look at the healthcare system level, this has implications for instance, primary care, because in the last chart that I showed you, a lot of those conditions are conditions that are managed in primary care. So things like chronic pain, type 2 diabetes, but we also saw that there is going to be a much greater increase in the most deprived areas, which means that there is a question about how do you how do you allocate resources, in terms of both healthcare settings, but as well as across different areas, like how do you decide that? So there is something to think about based on the results that we've seen. And we know, for instance, about the existence of an inverse care law, where primary care in more deprived areas has fewer GPs relative to health needs. So all of this is something that we need to think about when we do future resource allocations. Prevention is key. Obviously, all of the results that we talk about here are attributable and are driven by key risk factors. And so, yeah, we need to continue and think about population-wide government policies, tackling the biggest risk factors, things like the reducing the smoking age, and all of those things that are already in train, but also things to tackle obesity, which is a big driver of a lot of the results that we see in our research. But that won't be sufficient on its own. We also need to acknowledge the fact that a lot of these things are driven by the wider determinants of health. So things like poor quality housing, unsecure employment, lack of access to green space, lack of access to good public transport. All of these things are very important. So we need to think about that as well when we think about health inequalities. And then finally, just to make the point that, this is not, I mean, obviously we are a largely health audience here, but this has massive implications for economic growth as well, because like you saw, we are projecting an increase in working age ill health, a very unequal increase in working age ill health. And so this could potentially have knock-on effects for who is able to participate in the labor market, worker productivity, and it is a massive lost opportunity which could affect economic growth. And it's also exacerbating existing economic inequalities. The fact that a lot of that growth in working age ill health is going to be in the more deprived areas means that that is going to worsen economic inequalities. We've had research from other teams showing that also that this is not just whether you're in or out of the workforce thing. There are a lot of people, there are now as many people in work with work limiting health conditions as people out of work with such conditions. So again, employers potentially have a role to play there as well, because this trend will happen based on if risk factors are going to continue as is. So it's also about how do you then support people within the workforce and within different workplaces to be able to do whatever they can based on the different conditions that they have. So definitely employers have a role to play. And also things like the state pension age. It has implications for pension policy because, for instance, if we are going to see this increase in the state pension age, but if certain groups of society are getting major illness and potentially dropping out of the workforce much earlier in their working life, that then means that there is a high risk of them falling into financial hardship because they now have to wait longer to access their state pension age. And so, yeah, so this research touches on a lot of different things, implications for lots of different areas of work. And yeah, finally, just to say that tackling health inequalities is a prerequisite to economic prosperity. We can't really wait for economic prosperity to be able to tackle this problem. So yeah, thank you very much. And that's my email and my Twitter handle. And I put the full report with the technical appendix there if you're interested, if you really want to get would like to get stuck in the detail. We have a very meaty technical appendix, and the GitHub is basically the first link is us doing it's the real center side of the analysis. Dealing with the how do you identify conditions, how do we develop the Cambridge multimorbidity score using the patient panel that we have. And then the final GitHub is the IMPACTNCD model developed by the University of Liverpool, which, as I said, is open source, but it's not very, I wouldn't say it's like super easy to tackle on your own, but still, again, it would be, if you're interested in just finding out how the model works and things, they are in the process of developing documentation. And the aspiration is that, people are able to pick up and use it based on the analytical capacity that different teams have and things. But yeah, thank you very much.
Thank you, Anne. That was fascinating, and thank you for mentioning the meaty technical appendix. We like one of those, so I'm sure people will pursue those links. Mohammed has said in the chat that it's great to see such high quality work focused on long-term implications of health and care. He says, "Well done." So you plus team. That is really. It's extremely useful to look into the future, and it's very difficult, but it looks like, and you explained very well the methodology and how robust your approach was, and I think the results speak for themselves in terms of how important it is to consider all of those at the moment, and not to wait for prosperity before we put some of these things into operation. There's a couple of questions that we've had on the Menti, so I'm just going to share my screen, and so you can pick one or two of them out. We've got time for one or two of them. Let me see. So if you just go across the top, the first one says that you might have covered it in the presentation, depending on when the question was posed. But how have you accounted for undiagnosed people in the population?
Yeah, so this is, and I saw that this was one of the questions from Haka as well, which I wasn't able to address. There is unfortunately no way of accounting for the undiagnosed population. So if anything, what we know about access to care being more difficult and there being more barriers to accessing, for instance, primary care in the most deprived areas, if anything, our research and the extent of inequality that we estimate is potentially an underestimate, because we are not accounting for the undiagnosed population. And that could also be the reason why, because we thought about how, for instance, the major illness-free life expectancy gap is 10 years, whereas the healthy life expectancy gap, for instance, is 20 years. And I think a little bit could be that as well. I mean, they are fundamentally, you can't really compare the two measures because you're measuring like very, very different things.
Yeah.
But it could be that, for instance, if we were to have some way of getting the true prevalence of these things. Currently, all we're getting is the diagnosed prevalence of these things. It might be that that gap is actually bigger. I mean, we can't really say, but it's possible and probably closer in line to the healthy life expectancy gap. So yeah, unfortunately, we don't really have. So Liverpool actually they have other work where they are trying to get trying to find out the undiagnosed prevalence of things like, I think, cardiovascular disease and one more other condition. So if that work progresses and they are able to get robust results at the end, I think the idea is that we would then try and incorporate that into the model. So there are ways, but I mean, it is a limitation of patient records is, you have either one or the other. You have, if you have self-reported health, obviously that then gives you a very detailed look into what people feel, but then it's probably maybe less comparable and slightly more subjective, whereas with health records, it's maybe a more objective measure, but we have this problem of it's only measuring what is included in it. So,
yeah, and I say it might it'll vary probably depending on the disease and so on.
Yeah,
I used to work in public health intelligence, and it was and everybody who works in public health intelligence will look routinely at what they consider to be sort of undiagnosed population. So there'll be a feeling for what and where they are. So there might be sort of an adjustment that could be done just to try and sort of reflect that. But yes, it does feel like if that were sort of addressed, that it would make the situation worse. It would increase health inequalities. Thank you for pointing that out. Next question was, did you look into the correlation between occupation and health as well? I think you did, and that would make a difference in supporting people. It's a big thing, that, isn't it?
Yeah, so I think the thing is, so it's very so in the model, basically, Chris, our key, the person who developed the model, Chris Kyprodemos, they have a very high threshold for including. So this has to be studies where we have causal evidence of the relationship between risk factors and different long-term conditions. The thing with the wider determinants of health is that information is very patchy still. And because a lots of things, if you looked at occupation, that there is so much like confounding with like other factors as well. So sadly we haven't. It is an aspiration, and it depends on whether we have like robust studies which are able to properly unpick that relationship. But currently, I mean, when I talk about the labor supply and things, it's we haven't really looked at any of that. We don't have the information in the patient data, for instance, about the relationship between different conditions and their ability to work. We do have it in surveys, like the labor force survey, for instance, but we don't have that in patient data. So it is, again, an area ripe for research. I think with some of the great linkages that were being mentioned at HACA, for instance, I think this is something that, and it's a very important policy topic as well, based on the ONS figures that we've been seeing. But yeah, we haven't been able to include that in our research.
Okay, thank you. So this next question, have you looked at the modeling the effects of, on inequality of changing some of the risk factors, and might this be that are most, I can't read today, that are most amenable to public health interventions? I know you've mentioned them, and obviously the sort of obesity, smoking, and alcohol consumption and so on. There are public health interventions associated with all of these, but some presumably in terms of modelling the impact of the evidence that you have are more amenable than others.
Yeah. So again, we haven't really done this, but that is something that can be done with a model. So the model is actually built for putting in policy scenarios where you tweak different risk factors based on the information. So either it can be completely arbitrary. I mean, you can just put in like a theoretical number, like a 10% across the board, or, different numbers for different population groups. Like you can do any sort of combination like that. But also if you had papers that actually said, for instance, this intervention meant that we would be able to reduce obesity by X, you would then be able to use an actual tested policy to then be able to see what that how that changes. I have to say that for a lot of these things, it's not going to be as simple as, oh, we do something now and it's going to start showing benefits like tomorrow or even like next year or even in the next 5 years. There are big lag effects in how these risk factors feed into different conditions. And so even the smoking policy, for instance, that is something that actually our team at Liverpool have checked, how that would then affect multi-morbidity, I think, rather than health inequalities. And the thing is, if you are doing something now that will prevent young people from taking up, from new smokers, coming into the population, but it would only start seeing an effect when those people actually become old enough to then pick up diseases. So it is really something that you'll have to, but then obviously the longer the time horizon is for projecting something, there is more uncertainty. So there are lots of these different things that you have to think about. And so, but absolutely that the model is meant to look at, to be used in that way. But it's just that, we haven't really used it, and we don't have any results to show.
Okay. The next question is around, are there early indicators to see if interventions are working? So we just talked about that. There is a long lag for, again, having worked in public health, these are about decades. It's that you can wait to hope to see an impact.
Exactly. So I think, like I mentioned already, it's going to be, I think From what I remember, even if you like switched off a risk factor completely, I think the least amount of time it would take is still would be like 5 years for a specific condition, for instance. Like it's all there in the technical appendix. You can see what the lag effects are for the different risk factors and how they affect. The lags are different for different conditions. And so, yeah, it would still take time. And yeah.
Yeah, a long time, but it's still worth modeling. Is it? This is
Yeah.
the whole point of this is
Exactly.
yeah.
Yeah. That's not to say that we should, ignore this and, because we just kick the can down the road because there is no point. It's only if you start now can you start reaping the benefits. And I think that's the problem with like policy making as well, is generally because, governments don't really think in terms of such long
Yeah.
time periods. I think that's always a risk that we have with public health policy. But that's where we need to say that, like, if you didn't do any of this, like, this is what's going to happen. So,
Yeah.
Yeah.
And of course you've talked about the financial implications as well. So that
Yeah.
gets people thinking, doesn't it?
Yeah.
So the next question is, do you think maybe that smoking and alcohol consumption may have decreased in some populations, but then the risks, I think there's another part of this, but the risk it's increased with other things such as poorer diet, with more takeaways and dessert shops? There's loads of those now, actually. They're all over the place. So, yeah.
Yeah. So smoking. So the thing with alcohol actually is that it has decreased. But if you look at I can't really remember the trend by inequality, but the prevalence of alcohol consumption is actually higher in the less deprived areas. If you look at health survey for England, rather than the more deprived areas. But if you look at specific aspects like binge drinking, for instance, or alcohol attributable deaths, they are greater in the more deprived areas. So there are lots of different elements. So if you just looked at, daily units consumed, which is the metric that's used in health survey for England, that's actually higher in the more affluent areas. But yeah, no, there are. I'm not really sure about the relation, the sort of the combination or the sort of multiplicative effects of different risk factors. But I would imagine that, yeah, if you were to have multiple risk factors, there is definitely a bigger risk of incidence of conditions.
Sure. And so the final question we have here is someone said it's an excellent presentation, and indeed it was. But is it a nuanced assessment in any way, considering there could be a high income persons living in the least deprived areas? What's the thin line, and how does that affect health?
I mean, we always have this problem with deprivation. Deprivation is not a perfect measure in any way. First of all, it is a relative measure. So it's not really telling us anything about absolute levels of deprivation. And also, it is an area-based measure, like the person rightly mentioned. It is not an individual measure, which means that you would have these instances of, exactly like you said, high-income persons. So I think that is always a limitation that we just have to accept. It's because it's been used so much only because it is so well, I guess, linked with things like healthcare data. It's very hard to find an option where you have full patient records, but also patients' income or employment status. Ideally, that is sort of the gold standard, right? If we were to do health inequalities research, it would be individual based, very rich measures that is not grouping together many things like the IMD is. But sadly, yeah, we are limited in the way that because IMD is quite widely used and very easily linked, that is what people sort of default to. But I totally take the point that there are many limitations for the measure. Yeah.
Okay, but it doesn't detract from the usefulness of the results in the report and how it should be used. And so coming on to that, and you probably mentioned it in the presentation. So what happens next with the work that you've done here? How are you going to build on it? How's it going to be used? Who are you going to influence? Who's going to do something as a result of this to make a positive change?
Yeah, so we've had meetings with stakeholders, senior stakeholders in the Department of Health and Social Care, and OHID are quite aware of the Office for Health Improvement and Disparities. They are also quite aware of this research as well. So what I want to do as a very small sort of supplementary output off the back of this is, so we have been getting like loads and loads of interest from ICBs asking, can we do this for our patch? Like, is this something like, what do we do? Just like projections at a local level. And so I think we're increasingly recognizing that we need to do something at a subnational level, and that probably has loads of use. The only thing is, obviously, the data that we have is a nationally representative patient sample. So that's not going to accurately reflect the distributions of different illnesses that we have in specific conditions. But it is something that we're thinking about when we think about a future work program, is having something that is at a subnational level for sure, which then reflects some of these nuances at a more local level. What I'm doing as a small supplementary piece is actually using this won't include projections. It will include the current data, but trying to have some sort of a map where I estimate for a given age, sex, IMD, because we have, every LSOA, for instance, has an IMD decile attached to it, showing how this looks at a geographic level. So just having a map that aggregates, the share of people with major illness or the share of people with chronic pain, and then looking at that at maybe an ICB level or a local authority level or even a combined authority level. So that is something that I'm hoping to put out like fairly quickly as something that people can then maybe like interact with. So we're still talking with our comms team on how we put that out, but that is analysis that I can almost like extracting the juice from what we already have. It's just presenting the data in a different way because we haven't really had any maps or things in the report. So that's just that. But essentially I think subnational is something that everybody in the team are thinking about increasingly based on the kinds of interest that we received.
Yeah, absolutely. And so everybody in the audience today, that's what everybody will be wanting to see. We all have our sort of own understandings of health inequalities in each of the areas, but having a tool or having the ability and evidence to generate information about what it might be looking like in the future in order to demonstrate, yes, we need to do this now, is always very useful to have. There was just somebody who responded saying, thank you for answering the question. They do wonder if we'll face, this is probably our last question, I wonder if we'll face a challenge of smoking and alcohol consumption falling in certain populations, but then poor diet and vaping providing new challenges. There's always something new, but this is a real thing, isn't it? The impact of vaping and poor diet and of course tackle the supermarkets next, I imagine, is on your list.
No, I think the thing with poor diet actually is, again, I think with the model as well, for instance, we don't really look at, I mean, the model is 30 plus, so we don't really look at, for instance, trends in childhood obesity. And there is a whole, we know that the picture there is quite bad as well in terms of health inequalities and how that then feeds into your health as an adult from childhood as well. So so there are loads of things. I think poor diet is already quite well established. I feel like obesity has to be the next big risk factor that needs to be tackled because, again, like I said, in our model, that is one of the biggest drivers across the different conditions, along with smoking. But BMI has a big role to play in some of these patterns that we see. And vaping, obviously, like completely sort of uncharted territory. I don't know if we have, I know there are studies coming up about how it affects, your biology and things. But and the different risks of illnesses. But there will be new things, I guess, that would come up, which then means that we need to think about what risk factors we include in the model. I think already for the next iteration, which would be, I don't know, in like 2 to 3 years, maybe, the Liverpool team are going to include specifically sugar and salt, because that's an area where they have already done a lot of research, because they are epidemiologists. They've already done a lot of work in that area. And so I think they are thinking about, again, using data, including that as a specific risk factor to then see how that increases the risk of different conditions.
Okay. We'll look forward to that. Okay, Anne, well, thank you very, very, very much for sharing that with us today. I say you you had a practice run at Hacker, you know, that a couple of weeks ago, but this was the real thing, clearly. So thank you very much for coming. We'll pop the recording on the website, on the Midlands Analyst Network website, and I'll put your presentation slides up there as well. And you've at the end of those slides, you've given those very helpful links, and I think your contact details were on there as well.
Yeah.
So should people want to follow up? Coming up in the next few huddles, we've got the Empowering Futures, Growing Up Well in Warwickshire, and that's their joint strategic needs assessment. Looking forward to that. NHS Horizons are going to be joining us in a few huddles time, and we have real world data science forecasting the health needs of a changing population, and that's with Luke Shaw. Again, that's in, I think that may be the next huddle or a couple of huddles time. We are currently reviewing and are about to launch our new training program, so I'll share that with you here as well. But in the meantime, I'm going to thank you all very much for coming. Thank you again, Anne, for sharing the work of the Health Foundation with us. We'd love to have you back again, obviously, at some point in the future. These slots, the huddle slots, get booked up very quickly, so I'm very keen to get these booked in, even if it's a few months from now. And I'll see everybody again in a couple of weeks. But for the time being, I shall give you 4 whole minutes back. I'm feeling very generous today, so thank you very much. Thank you, Anne. Thank you, everybody, and bye bye.
Thank you so much. Bye.
Bye bye.